Hello, my name is Nicole Rossi, and I'm a Semester 4 undergraduate nursing and honors student. For my senior honors project, I decided to do a study on the implementation of the recovery care model in psychiatric nursing practice. Professor FM was kind enough to allow me to post a presentation on this important model and about my research so that hopefully you all will take this information into your own future nursing practice. So, how did I come up with this project? During the chronic illness course, Living Successfully with Chronic Illness with Dr. Sobel, I had to do an honors option assignment where I would begin culminating references for my honors project. She asked me where my interests lied, and I immediately thought of mental health. She recommended that I talk to Professor FM, who I had the semester before in the Impact of Chronic Illness class. This class actually ignited my decision to switch to nursing in the first place, and I especially remember connecting to the lecture on the recovery care model versus the medical model. I have a passion for mental health and truly care about reducing the strong stigma associated with the field and advocating for clients involved in this care, and recovery care is the absolute best step in that direction. With all of that in mind, I wish to research the difference between these models and whether this evidence-based recovery model is being implemented to its fullest potential by psych nurses in this area that we serve for our psych clinical, for example, at Crossroads at Augusta, Western State, Arbor House, etc. Although my project focuses on nursing, the recovery care model is imperative in interdisciplinary practice as well in order to provide the most optimal integrated care. Before I delve into my project, it's important to provide some general background information on the recovery model, medical model, and what current literature and practice are depicting. It will be important for you to understand this difference and what the recovery care model embodies for Nursing 357. The recovery care model is the recommended best practice model in caring for mental health clients and has replaced the traditionally employed medical model. The medical model focuses on the pathology, diagnosing it, and coming up with a treatment plan that is determined by health professionals. This model of care focuses more on the illness than the clients and their personalized needs. The healthcare providers tell the patients what to do and control decisions in a client's care. On the other hand, the recovery care model is patient-driven, holistic, and hones in on finding a way for clients to live happy, meaningful lives with mental illness rather than allowing it to control them. The recovery model is a more therapeutic approach than the traditionally employed medical model and sees the nurse-client relationship as a partnership. It holds that psychiatric clients are more than just their illness and that the illness does not define them. As opposed to the medical model, the recovery care model expands past the client's medical needs and acknowledges the importance of promoting personal development. The Substance Abuse and Mental Health Services Administration states that the recovery mindset is more centered on mental health care being a healing journey that fosters meaningful client integration into society while striving to achieve the client's fullest potential despite their mental illness. It is important to find the treatment plans and tools that support adherence, but there is more to account for, and the ultimate plan must be tailored to each unique client's wants and needs. The driving premise to recovery is the idea of empowerment and instilling hope into clients during their care. Healthy living, having a stable home, finding and maintaining a purpose in life, and having a sense of belonging in a community supports a life of recovery. The United States Department of Health and Human Services Substance Abuse and Mental Health Services Administration developed the 10 fundamentals that define the recovery care model, including self-direction, individualization and patient-centeredness, empowerment, holistic, nonlinear, strengths-based, peer support, respect, responsibility, and hope. All of these factors are key in implementing the recovery model and involves both the nurse and the client. Self-direction allows the patient to take control of their care and make educated personal decisions. Individualization and patient-centeredness refers to basing care on the unique person behind the illness. Empowerment involves giving authority to the patient in managing their care and positively impacting them in their search for their place in society. A holistic approach takes into account all facets of the client, not just the physical, which is the sole focus of the medical model. Nonlinear refers to making sure that the patient understands that recovery is not necessarily a smooth journey, but has some setbacks that can be overcome with the focus of continuous growth and experiential learning. Strengths-based care focuses on the patient's abilities and using them to allow the patient to take on new life roles. Peer support is making sure that the patient has a supportive group where they feel a sense of belonging, which includes family, friends, and support groups specific to his or her condition. Respect includes feeling acceptance and appreciation from society and others so that the client feels fully integrated despite their mental illness. Responsibility includes making sure that the patient understands that they need to manage their self-care, adhere to treatment plans, and effectively cope so that they live a happy and well life. Finally, hope is the nurse or healthcare provider sending positive messages that the patient can successfully overcome obstacles and find personal success in their own recovery journey. All of these factors are key in implementing the recovery care model and involves both the nurse and the patient, as mentioned before, and also empowerment and hope are key factors in this. I will not cover the information on this slide, but make sure to check out the RAP plan link in this week's module. This is an important recovery-based intervention that is highly individualized and patient-driven, and you need to know about it. You are more than welcome to pause this presentation if you want to write down notes on the steps. After researching the current literature, the recovery care model is the best practice model and provides the most successful and personalized patient care and produces more long-term benefits for the patient. There is a better chance of treatment adherence, continuity of care, effective self-management, and achievement of individualized recovery. Also, the idea of recovery from mental illness is actually not a new concept. The mindset of actually implementing it in psychiatric nursing care has been a slow process and has been included in the mental health nursing scope and standards of practice since 2007. A noticeable theme from the literature was that nurses appear to be more focused on paperwork, administering medications, and maintaining unit safety more so than direct patient interaction, and do not receive proper education nor encouragement to implement the recovery mindset. Traditional U.S. mental health care has focused on the illness in patient care and just telling the clients what to do, when in reality we need to allow for more patient decision-making, building on their strengths and advocating for them as a partner in their care, not as a dictator. This fosters the idea of self-efficacy and improves continuous in-treatment adherence. Although efforts have been made to implement this model, there is still much work that needs to be done in order to use it to its fullest potential, and nurses and interdisciplinary teams need that education piece so that the mindset becomes a habit of practice. Now that you have background information, I will move on to talking about my honors project. The purpose of my study was to examine whether the evidence-based recovery care model is being implemented to its fullest potential by psychiatric nurses in the Augusta, Rockingham, and Stanton communities. Based on the results, I hope to enlighten nurses about what is currently being done in practice and identify areas that may need strengthening in the psychiatric nursing contribution to recovery. These areas will be examined as the 10 fundamentals that were discussed earlier on in this presentation. In the study, I enlisted the help of psychiatric nurses and client participants so that I could compare both views and draw a bigger picture of this model's use. The psych nurses came from facilities in the area like Arbor House, Western State Hospital, and Crossroads at Augusta. The psych clients were from the Shenandoah Clubhouse in Stanton and Summit House in Harrisonburg, which you all will experience in your clinical rotation if you haven't already, and have been in the acute psychiatric clinical system before. This clubhouse participation is voluntary, and the clients have been pre-screened by a qualified mental health professional based off their cognitive, functional, emotional, and psychiatric abilities. They are able to understand their treatment condition, appreciate the benefits of treatment, can reason potential risks and benefits of their treatment, and are able to express choice about their treatment. Therefore, they were deemed competent for this study. I assured that the clients could give consent based off clubhouse staff and clinician knowledge, which is Professor Fauci-Maphis, in addition to whether they have a power of attorney or a guardian on file. The two variables being studied are the 10 fundamentals of the recovery model and the quality of recovery-oriented care given from the perspective of both the client and the nurse. My goal was to gain the consent and participation of at least 10 nurses and 10 clients via the Qualtrics survey that I came up with, but I ended up with 8 nurses and 15 clients. There were 10 Likert scale questions, with each one based off of each of the 10 fundamentals. The mean value for each fundamental was calculated, with 10 being the highest for both subject groups, and this value shows which fundamentals are being used more so than others. Then I added up the mean values that I just discussed for all the fundamentals together to depict a total recovery care score, with 100 being the highest, and this will paint an overall picture of recovery care model implementation. Then I averaged both the nurse and the client recovery score to get a culminated score. This will become more easy to understand further on in the presentation. I also included some qualitative questions which were not meant to say whether or not the model is being used, but to see what current efforts are being made towards or against its use, and any comments on aspects of the fundamentals. The surveys that I handed out did not have any identifiable info used except for whether the participant was a nurse or a client, and my project was IRB approved. Participants were notified of the results of the project at its end. As mentioned in the previous slide, there were two Qualtrics surveys that I created, one for the nurses and one for the clients. The nurses received an email with a link to the survey in order to accommodate their busy work schedules and provide some flexibility so that more people would be able to participate, while the clients took the survey on nursing department-issued iPads or Clubhouse computers after a brief presentation about the recovery care model was given so that they had an understanding of what they were giving their input on. I am not going to stay on this slide for too long because it's a lot of different words, but here it is just in case you would like to look at the survey questions, the Likert scale ones for the nurses. If you really want to look at it, you can pause the presentation. And here's a similar slide, but instead it's the Likert scale questions for the clients. And then here's a slide of the qualitative questions for the nurses. And here's a slide for the qualitative questions for the clients. Here are the results from the Likert scale questions on my surveys. Overall, clients rated every fundamental as being lower than the nurses did. Each group had different fundamentals as being the lowest and the highest. The nurses saw self-direction, individualization, and responsibilities as being the weaker fundamentals in their care that they deliver, while the clients saw strengths-based, peer support, and respect as being the weakest part of nursing care that they received. I was surprised by these categories because I came into this project thinking that self-direction and individualization would be seen as weaker from the client perspective and not from the nurse's perspective. On the other hand, the highest categories from the nurse perspective are holistic, nonlinear, strengths-based, and hope, while clients saw responsibility, individualization, and hope as being the strongest. Two of the three lowest nurse-rated fundamentals are being seen as the highest from the client perspective, so nurses are actually doing better than they perceive in individualization and responsibility. However, nurses rated strengths-based as being one of the highest, and that was the lowest rated fundamental according to the clients. It was great, though, to see that nurses and clients believed that hope was one of the strongest perceived fundamentals in use. After adding up the average fundamental scores from the previous slide, the nurses gave their recovery care a score of a 90.78 out of 100. The clients gave the nurses a recovery care score of a 72.32 out of 100. And when averaged together, they gave themselves a total of 81.55 out of 100 for nursing care with recovery. If taken from a grading standpoint in nursing school, nurses actually gave themselves an A-, clients gave the nurses a C-, and the average is a B-. These results aren't awfully low, but change still needs to happen in order to bring recovery care to its fullest or 100% potential use. Although qualitative data did not determine the overall recovery score, I wanted to see what each group said about the different roles and efforts made towards recovery care. There were more positives, which shows that nurses have been making strides, but some of the comments for change were alarming. For instance, some clients said that their rights were limited, that nurses had little to no discussion with them and drafted plans without any input from them, said that nurses don't respect me and therefore I don't respect them. No one gave me the tools, it came with time on my own, and this one actually was the most shocking to me, and that is, they don't give me hope, they make you feel miserable. And with recovery care model, hope is basically the centerpiece in delivering the most optimal care for these mental health clients. And I feel like in any general care out there for whatever specialty you decide to go into. So by hearing that, it's really sad and shows that yes, change still needs to be made so that clients don't feel this way and feel like they are being respected and cared for and are able to reach their own version of recovery. So based on these results and the disparities between the nurse and client perspectives, some improvement still needs to be made towards achieving the best recovery care in psychiatric nursing. Based on the data, I would say that strengths-based, peer support, and respect are the fundamentals to improve upon, since they came from the client perspective and they ultimately are the receivers of care. But since all the categories are low, there still needs to be improvement on all of them, but these are the specific ones that nurses in this area can focus on in particular. I am just a student and do not have the years of personal experience in psych to make recommendations on what to do specifically, but education and changing the overall mindset of psychiatric nurses can help bring us further away from the traditional medical model. This project could be a basis for change since results showed that all aspects of the recovery care model are not being used fully. Ultimately, as nurses, we want to provide the best care for our clients, and by enlightening nurses to areas that may need strengthening in regards to the evidence-based recovery model, we can achieve that level of care. This model is applicable to all disciplines and whatever part of nursing that you decide to pursue, and by taking into account client autonomy and fostering hope and empowerment in our clients, we can facilitate better self-care and overall recovery in any condition, especially with psych. My project was not perfect by any means, and there are definitely areas for improvement that if I were to pursue this later on in like a graduate program or something like that, I can make changes to. For instance, the sample size was way too small and the data could have been more rich if more nurses and clients decided to participate. The question verbiages for clients were a little bit difficult because they struggled with the meaning of words. I should have considered this aspect more when wording the questions and would change that in the future. Although emails were convenient for me to send out for my survey, I did not have a guaranteed response from everyone that I emailed, like with the in-person surveys with the clients. If I had to do this process all over again, I would definitely meet with the nurses in person. For the data selection process, there was a lot of convenience bias when choosing the nurses because I went off my advisor's network in the psych realm, which was easier for data collection purposes, but in order to get a better representation of nurses in the area, I could have found a list of the nurses in each of the facilities and then selected them randomly based off that. And last but not least, the clubhouse member selection bias. The heads of the clubhouse actually chose the client participants for me, which could hold some bias potentially. I noticed that very little outspoken clients were chosen, and that could have been an unintentional selection bias, but I thought I would address this just in case. So that concludes my presentation to you on my project and the recovery care model. I would like to thank my advisors, Professor FM and Dr. Sobel, for helping me during this process, and strongly encourage all of you to pursue research at some point in your nursing careers if the opportunity arises. If you have any questions, feel free to email me, and thank you for listening.